On behalf of the Association for Vascular Access and the I Save That webinar series, I'd like to welcome you to tonight's webinar sponsored by Adhezion Biomedical, Mitigation Strategies to Reduce Vascular Access Risk. I'm Blake Hotchkiss in the AVA Education Department. Joining with me today is Judy Thompson, Director of Clinical Education, and Dr. Joan Ralph Weber, our speaker for tonight's presentation. So a lot of credentials. She is an oncology, hematology, and palliative care clinical nurse specialist. Throughout her more than 35 years of nursing, she has focused her career on vascular access as well as supporting patient lives during their oncologic journey. Joan uses her competencies in coaching, education, consultation, research, collaboration, and leadership to optimize the care of her colleagues and patient population. She has been a member of the Institution Review Board, participating in many clinical research trials, and currently mentors evidence-based projects. In addition, Joan is an adjunct professor lecturing at a variety of conferences locally, nationally, and internationally. And with that, Dr. Ralph Weber, I'll let you take the stage.
Well, thank you very much for allowing me to share my experience and to share the mitigation strategies to reduce risk in vascular access. Some of the objectives that we will cover today, we will talk about the role of tissue adhesive, vascular access device in the risk reduction. We'll also consider COVID-19 crisis impact on vascular access device care and maintenance. We'll also analyze tissue adhesive properties, including log reduction and microbe immobilization. We'll also describe the impact of tissue adhesive on securement, stabilization, and catheter migration. We'll also look at the evolution of cyanoacrylate tissue adhesive and its role in vascular access device management. We'll also look at the evidence describing the use of tissue adhesive to secure and protect vascular access devices. And lastly, we'll analyze the impact of CLAPSI rates when sealing the vascular access insertion site with tissue adhesive. I have a disclosure slide, relevant financial relationship that during my pilot study, Adhezion Biomedical did provide the product for me for my study. And of course, I will not discuss any investigative uses off-label. So I just wanted to include some abbreviations for you all as well, and I won't go through them all, but there they are, just so that you have an idea of when we use with abbreviation that you know what we're talking about. So moving right into what is tissue adhesive. Pretty amazing. I sat in a conference a couple days ago and was able to share exactly what this tissue adhesive was and how exciting it was that we were using it. Well, what this is actually a glue. So it's a liquid monomer that has a rapid conversion to a polymer when it comes in contact with moisture on the skin's surface. It chemically changes into a polymer that binds to the top epithelial layer. This polymer forms an acrylate bridge, and what it does is it binds the two wound edges together, allowing normal healing to occur. This conversion from the monomer to a polymer occurs rapidly, and it really prevents seepage of any adhesion below the skin margins as long as the edges are well opposed. What we notice though when this healing or the smaller polymer takes place, that we do have a change in temperature as well. Some patients may experience the heat, and there again, it's dependent upon the type of cyanoacrylates that we've been using. Also important to note is that there is an antimicrobial element to the activity with the cyanoacrylate. So just a little bit of an evolution of the cyanoacrylate. Just wanting you to know where it came from and how it came about. Way back some time ago, it was used as an organic compound in industry, especially for plastic bonding with the automotive and cementation as well. It then advanced a little bit to ethyl cyanoacrylate, and it was what we noticed with that is that it was very brittle. It was able to withstand vibration and impact resistance, And what we noticed was that it could hold up to 2,000 pounds. Some of you will remember crazy glue, and that's exactly the type of cyanoacrylate we're talking about there. Our first medical adhesive came along in the N-butyl 2-cyacrylate, and it was the first topical medical adhesive, which was quick drying, brittle, stronger, and it had that ethomeric reaction, which requires a minimum of 24 hours before it's fully water resistant, and that's our Histosil. And then, of course, we come to the newer portion of cyanoacrylate, and we're looking at the 2-octyl cyanoacrylate, which is 4 times stronger than the previous one. It polymerizes in seconds. It is less toxic, and that process of heat, where heat is experienced, is lessened. So therefore, it's more flexible. It has that increased tensile strength, and it has immediate water resistance, which is important, and it continues to have that microbial properties. When we also look at the evolution of this type of tissue adhesive, we also look at how it's been used in over the years, and you can see that it was first, the first formula was identified in wartime, and it was used to with rejection. Commercially, it was also used with the Kodak, and then again, we have TV commercials that were touting the strength of that glue. We also found that in the 1960s, moving forward, that the tissue adhesive was submitted to the FDA to use to seal human tissue together. It was a spray that was used, then tested by the surgeons in Vietnam. So when they were in the field, they were able to go and quickly attend to the soldier, be able to spray this on. Unfortunately, it wasn't something that was received and therefore was not continued to be used. The other, it's gone through several other products. You can see throughout the timeline that we have gone through many improvements and formulation modifications since then to achieve some of the characteristics that are important to the clinicians for specific purposes, like vascular access device. The use of the tissue adhesive as a barrier against common microbes is known and approved by, or was known and approved by the FDA in 2001. You may not know that this formula has been extensively used in veterinary care as well, and even used internally in humans to immobilize cerebral AV malformations, pseudoaneurysms, and some GI bleeds as well. Some of the earlier studies of using tissue adhesive with vascular access did not use this highly purified formula that is in use today. However, these studies added to the growing body of knowledge, which showed the benefits of tissue adhesive with vascular access and demonstrated some of the characteristics that are important for our devices now. Currently now, the formula which we are using, the 2-octyl CA, received FDA approval for use with vascular access for securement, insertion site sealant, and a microbial barrier. And that would be in 2018 when we see the first US sale of FDA for clear. We also, when we look to vascular access devices, we also look at the failure rates within our vascular access. You can see we have occlusions, dislodgements, migration, some vessel trauma will occur, some thrombosis, phlebitis, infection, infiltrations, and skin damage or MARSI. When we look at the peripheral catheter failure rate, we are looking at the information that was provided to us in several studies. Looking at Dr. Helm and Associates with a problem with the PIV device failure rate in their 2015 publication titled Accepted and Unacceptable. Dr. Helms was a thoracic surgeon and suggests that there was this level of acceptance that PIV complications were acceptable. He didn't believe that they were, but he thought there was a relevant element to it, that they were acceptable, but really, truly, we weren't. Looking at all the study types, we were looking at the minimum failure rates of 30%, maximum failure rates of 95%. Some of the failure rates which are included there with infiltration, extravasation, occlusion, accidental removal, and phlebitis. We also had a dislodgement rate of 3 to 10%. Patients will pull through major cardiovascular surgeries or thoracic arterial surgery repairs only to have their discharge delayed due to a PIV infection or a fever. Often the discharges were held, but there was never, what was interesting enough is that even though these were occurring, there was really never any discussion about how they would go ahead and prevent this from happening. In 2019, there was an update with the peripheral catheter failure. And again, Dr. Helm reported up to the 63% PIV rate, as we mentioned before, with still no resolution or any significant difference in managing, stabilizing a PIV device. In 2019, a follow-up article occurred, and he mentioned then at that time that the supportive tape was simply not adequate, that he challenged that those looking after PIVs, that the care must include clinically simple, highly reproducible, cost-effective interventions that would stabilize PIVs. When we look at the adhesion strength of an IV catheter use over time when using this tissue adhesive, you can see we have two types of catheters in this slide here. That we had an AutoGuard catheter and an Nexiva catheter, and the securement method was the Secure Port IV, which is the tissue adhesive. And you can see the adhesion strengths and the time intervals made out there: 30 minutes, 6 hours, 1 day, 3 days, and 7 days. Looking at the overall securing of AutoGuard catheters, you can see that that was quite successful. Securement and stabilization needs. You know, in 2016, Barton suggested, dependent on the patient's needs and clinical situation, a securement device and stabilization device needs to be clinically aware and also inexpensive and reliable. There was a concept of these subcutaneous clips to a secure port PICCS was introduced. They found that these clips were very expensive, painful to the patient, and difficult to remove. And what was interesting was that the outcomes did not improve with the innovation, only when a robust educational program was provided prior to the implementation. Tissue adhesive discussed at this time as efficacy to decrease infectious complications and bleeding at the site of the insertion site. However, more evidence was required before they would even consider implementing this practice. They also discussed that causative influences for adequate fixation, and that we needed to have more of causative influences to look at these reasons why for securing these catheters. Also, design enhancement and inexpensive and reliable. When Inwood looked at this type of standard dressings and techniques to secure catheters and to prevent migration of the catheter, he looked at several of these securement devices, looking at design enhancements, and also looking at what was available at the time. He also looked at adhesive glue, and he found that this glue could potentially be a solitary securement in compliance that would fit these individualistic purposes and to reduce bleeding at the insertion site. When we consider CVC, CLAPC, and the economic impact to the US, when we look at the CVC usage, we see that we have well over 5 million inserted each year, with considerable CLAPCs, DVTs, and occlusion. We look at the failure rates for CLAPC, and this is literature from 2011, where we had almost 72,000 CLAPCs for the year. We had an occlusion rate of 36%, poor securement and stabilization and dislodgement, and dressing maintenance was a concern with the failures. And then when we looked at the cost associated with these failures, we found that there was $47,000 per incident. And I can be assured that that number was much higher when they involved eclampsia. Of course, then we had lost work days, pain and suffering, and long-term mobility. So you can see, looking at this schema, that the amount of catheters that we're using, CVC catheters, the failure rates, and the cost associated, that it truly does give quite a high economic impact to the US. Looking to the evidence, and that's usually where we go when we're looking for studies. When I went to look for evidence to support why I was going to use tissue adhesive, I looked at several of the studies to see what was available. There was information that talked about peripheral catheters and the use of glue. There was also PICCS, non-tunneled and tunneled arterial lines, and even one study out of Italy had epidural lines. But most of these studies that I found were using the N-butyl formulas designed for wound closure. 2017 comes along, and we have the first FDA cleared product for securement and protection of vascular access sites. This was the glue that we were talking about, and based on that, when the more evidence came out, unfortunately it wasn't published evidence, but there was evidence, and several centers were using it. 2018 and 19, we were seeing several poster presentations with regards to the use of tissue adhesive. And of course, resulting from the study that we had out of Mayo Clinic in 2020, there is now a publication discussing the benefits associated with this new solution. It was on a pilot study, and the pilot study continued on, and I'll go through that in just a few minutes. But there is now a journal article that talks, and currently right now, we're seeing a lot more information, a lot more published evidence to support the use of this catheter securement. Here's just some presentations from AVA from 2019. I won't go through that, but you can see on the right-hand side the various topics that were discussed, and a lot of information. And as I said, the conference that just finished a couple days ago had even more presentations to support the use of the glue. When I was looking at evidence to support starting my pilot study, these are some of, I have a few of the articles and studies that were out there to help support this. So I just wanted to review a few of them with you so that you can see where the evidence that I use to support my clinical trial. So here we have a single site tertiary hospital in Queensland, Australia. The purpose of this study was to look at the effectiveness of 4 securement methods to prevent the failure of a peripheral IV. And failure rates were assessed as whether the catheter came out, whether it got had phlebitis, that type of thing. What we see here in this study, out of the 4, we were using the control, which was the standard polyurethane. Then we had the bordered polyurethane. Then we had the standard plus sutures, plus sutureless device, and then we had the standard along with the tissue adhesive. You can see the group, or the N number, was not overly large. They were in their 20s for most of them. And you could look at the catheter failure rates. Interesting to see that the standard polyurethane dressing with the tissue adhesive had less failure rates than any other. The conclusion that came from this study was that the tissue adhesive appears promising as an innovative solution, but that it may not be suitable for all patients. So that was the first literature review that I looked at. Another article that I chose, this was a single site, 2-armed, non-blinded, randomized controlled study of 380 peripheral catheters. And with this study, it was hypothesized that the addition of skin glue to the insertion site of the PIV in the ED, this study took place in the emergency department in Brisbane, Australia, that these PIVs would reduce the device failure rate at 48 hours. And there were 2 groups in this study. One was the standard group that received standard securement, and then the other group was they received the standard care plus the tissue adhesive as well. And the primary outcome for this study was looking at PIV failures at 48 hours regardless of the cause. The secondary outcome that they used was individual modes of catheter failure, which was infection, phlebitis, occlusion, and dislodgement. Some of the assessments that came from this study was that the PIV catheter rate was 10% lower with the skin glue. Dislodgement was 7% lower. Phlebitis and occlusion rates were less than this with the skin glue as well, but they were not statistically significant. Interesting enough, there were no infection rates at all. So this study supported the use of skin glue in addition to standard care to reduce PIV catheter rates for failure or for adults in the emergency department only. Another study I looked at was in a pediatric population. This was a 3-arm pilot study of 100 pediatric patients. The purpose of this study was to evaluate feasibility of the efficacy trial comparing a PICC dressing and securement techniques to prevent complications and failure. These pediatric patients were put into 3 arms. One was the standard care, which was a bordered polyurethane dressing. The next group was sutureless securement device, and then the third one was the tissue adhesive. So they looked at these 3 different methods of securement and compared them. Just of note here, the tissue adhesive that they were using at the time was Histoacryl. So when we look at this pediatric study that took place, the results show that there was protocol feasibility was established, that PICC failure was 6% less, or 6% with standard care, 6% with sutureless device, and 3% with the tissue adhesive. Basically, the complications were pretty much the same all the way along. However, tissue adhesive provided immediate postoperative hemostasis, prolonging that first dressing change until 5.5 days when compared with 3.5 days and 2.5 days with the standard care. Bleeding was the most common reason for the first dressing change as well. And this research suggested the safety and acceptability of different securement dressings compared with standard care, and that also that securement dressings may also reduce the number of dressing changes after insertion. However, the conclusion of this study, they did mention that innovative PICC securement techniques are safe and can be more effective than standard care. However, they were suggesting a larger study should take place. This is a relatively small study with only 30 participants. We also looked at another study of tissue adhesive with pediatric tunneled catheters. And this was a 4-arm pilot study. Standard care was compared to an integrated securement product, sutureless securement device, and tissue adhesive in 48 pediatric tunneled CVADs. So there again, we're a small number as well. What this study was evaluating was the feasibility of launching a full-scale randomized controlled trial that was going to take place 2 looks. So it was just the preemptive portion prior to a full-blown study. These are the results that they saw. They saw that protocol feasibility was established, that the failure rate with tissue adhesive was 0, and then in the standard care arm, that the CVAD complications were 0, also tissue adhesive and standard care. 1 CVAD-associated bloodstream infection occurred with the sutureless securement device. However, the overall satisfaction was highest in the integrated securement dressing, and they saw that there was an improved dressing integrity evident in the intervention arms with the integrated securement dressing associated with prolonged time to first dressing. Conclusions from this study show that there was an improvement in the security and dressing integrity of the tunneled catheter, and that it was likely to improve outcomes for pediatric patients. However, they also suggested that further research was valuable to identify other outcomes. We also had another study where we looked at the glue and CVC device insertions. This came from Dr. Pediatric, and it was in 2016. He presented a poster at the AVA scientific meeting sharing their experiences using tissue adhesive on a variety of CVC devices, leading to 100% controlling of the dressing from the exit site. They tracked and reported on just over 1,400 line insertions, so a great end for this study. They found that tissue adhesive reduced unscheduled dressing changes and sealed the exit site. What really this is amazing is that it computes to significant cost savings in supply and clinician time, not to mention the added risk to the patient due to early dressing disruption. Dr. Pediatric also concluded that tissue adhesive was inexpensive, safe, and highly cost effective. This was one of the studies that I really took to heart, looking at that high number that he had, and also the fact that the cost effectiveness of the product, and that it was safe for the patient, and that it was important with securement. You know, today we're all dealing with the pandemic. I'm sure there's not one person that hasn't been touched with COVID-19, but looking at the vascular access relationship with COVID and how tissue adhesive can help. Some of the suggestions here we have is that it reduces post-insertion oozing, which contributes to the unscheduled changes. Then we obviously would be conserving PPE in that instance. What we found is that with the post-insertion oozing, once the blood has stopped, if there is some oozing, and we apply the glue, that it seals it completely. Also, the increased use of CVC and femoral lines to seal the site and mitigate extraluminal microbial infection, and there again decreasing CLAPSI, which is so important these days. Also looking at the device securement, maintaining and securing that line, especially through the patient while they're in various positions. Pronation has been very popular with our patients with COVID, and having that ability to secure that device has been really beneficial. And also reducing the unnecessary exposure to that line dislodgement requiring device replacement. So you can see there is a relationship to the pandemic and vascular access and tissue adhesive. When we looked at the literature reviewing relating to vascular access, as I mentioned, I pulled those studies. What I found that was missing in the literature was evidence that the tissue adhesive could reduce migration rates. And that was a concern to me as I ventured on my journey for a pilot study. I also saw that there was an increase in popularity and use of PICCS. There was significant risks that were documented. However, this novel securement device showed effectiveness, as I just mentioned in the last study, and yet it was very challenging. And also, it was important to me to be able to recognize and to recommend cost-effective and safe securement methods. I was very challenged on that at first because of the expense. It was a concern that trying something as novel as glue, would it be more expensive? And we were able to find that there was cost savings with that. So we're looking at the experience that I had at Mayo Clinic. And what I did was, it was a pilot study that I started, a single site, non-blinded, non-randomized, comparative quantitative design. And what I was looking at was migration of PICCS. I was able to have 31 patients. I had 30, but actually 30 was the number that was given to me to show effectiveness with this quantitative study, that I could show that if it was effective, that the 30 would show me significance, some statistical significance. We have increased our beds, so in acute care, so we did have, back when this was first documented, 280 bed acute care hospital. The inclusion criteria was very simple. Patients just needed to have a 24-hour length of stay to have that PICC in. Our exclusion criteria, and this information was based on several of the studies I reviewed. We were looking for those that may have an allergy or sensitivity to the glue. If someone had a current bloodstream infection, we weren't interested for the pilot study to have them placed on, and or if there was diseased or non-intact skin. As I mentioned, the exclusion criteria came from the articles that I looked at from what they had suggested. We also looked at our measurement, our unit of measurement was that exposed visible length. So we use that measuring from insertion to hub daily with these patients. So I had to have something to compare the migration rates as what I was looking at. And so what I did prior to starting on our study was a retrospective, similar population who received the standard care device. I had used 30 patients that were the same. We used oncology, hematology patients, and used the same patients, or the patients that had that same diagnosis, and looked at their length of stays with the PICC lines. And there again, at that time, they were using different other methods to secure them. I looked at also migration rates on them. And so I calculated migration rates based on that information so that we would be able to compare. And the migration rate at that time was 19.35% was what came from the retrospective data that I collected. Because there was no formal data collection tool and I needed a reliable and valid tool, I was able to look at an inter-rater reliability agreement. And what that actually was taking 21 nurses and observing 2 patients with EVLs prior to the intervention. So that what they did was each one of the 21 nurses went in independently, measured an EVL on 2 patients. And that information was taken and looked at, and calculating that provision of agreement with those 21 independent observers, all but one person evaluated the measurement the same. So it was pretty good statistically to be able to have that information for us, which meant that those that were evaluating, and at that time was only the vascular access nurses that were documenting the sites and also measuring the EVL. So when we look at our experience with the tissue adhesive from our study, I mentioned it's a single site. We only did it at the one hospital. We took the medical surgical patients with PICCS that were greater than 24-hour length of stay, and it was on a hematology oncology floor. We looked at the EVLs. We measured at the time of insertion and then daily. And we used that control use of the CHG disc and the engineered securement devices. That was the retrospective, 30 retrospective patients that I looked at. And what we did was, for those that with our study, we eliminated the disc and that securement device, and all we used at the time was only tissue adhesive and a transparent film dressing. You can see there the migration reduction was pretty significant. We went from that 19.35 that I'd mentioned earlier to 1.4%. The information that I had from this study was taken to Nursing Executive Committee, and it was just a month study that I did. And they were so impressed with the results. However, 30 subjects wasn't enough for them. They wanted more, which made sense. In order to show effectiveness, they wanted to see more. So a year later, we looked at our patients, and I had collected 411 subjects on our study. Tissue adhesive had been applied to all those 411. All we used was the tissue adhesive and that transparent dressing only. As I mentioned previously, no engineered stable device, no chlorhexidine impregnated disc. We removed those, and for our study, we went just with tissue adhesive. As I've mentioned, we had a 1.4 migration rate, which was amazing. We had no adverse events, which was significant. Even better, there was no microbial contamination. We did have a little problem with glue buildup, and that was easily rectified with individuals from the company that came to re-educate us on how to apply. At the time when we were, this is one of the first studies that we did with tissue adhesive, We felt that there was tissue adhesive in that little container that we needed to use it all, only to come to find that that was not so, that minimally we should be applying drops of glue. So we did have a lot of buildup on catheters, as I mentioned, with the glue because we wanted to make sure that was secured so well. However, of late, we will use a maximum of 2 drops to secure, and that's all, and our buildup has been minimal. What we found true, though, that our cost benefits, there was positive cost benefits when we looked at just using tissue adhesive. And when we compared that to the cost of a disc and that securement device, found that there was, that we had really truly met our goal of significantly reducing migration rates with that cost benefit ratio. One thing that was very interesting to us, and this came about after the study was just about done for that year. And what this was brought to me by infection prevention individuals and said to me that, Jonah, are you aware of the CLABSI rates? And for a moment, I had to hold my breath because I was hoping that it wasn't going to be bad. But if you can see on that bottom line, that is with the tissue adhesive. I can show a whole year where we had no CLABSIs. Now, the line above without tissue adhesive, you know, is not a lot. There's a total of 5, but 1 CLABSI is costly. But you can only imagine how excited we were to hear that our study did not cause any CLABSIs at all, that that the securement device not only did the migration, was it reduced, but the fact that our CLABSIs weren't, there were no CLABSIs at the time. And I'm proud to say at this moment, we have continued to be able to maintain that. So just before we end, I just wanted to inform you all, looking at this slide here is often information that we as nurses don't really understand or know a lot about. So this is the immobilization and death of bacteria by a novel glue formation. And you can see here as this slide, we look at how immobilization and death of bacteria is attained by the use of this tissue adhesive formula. We're looking at log reduction, which is a standard test used in microbiology to test and compare how different disinfectant or cleaning agents impact microbes. Products are tested against 1 million microbes to determine efficacy. For example, many of the CHG preps carry a 4 to 5 log reduction, which means that between 10 and 100 microbes may survive, which may take up to 30 minutes or longer to see this change. This is really great news, but if you're that patient and you were one of those surviving microbes migrating into the vascular system, I'm sure we wouldn't be very happy. By comparison, most hand sanitizers are listed at a 6 log reduction, the highest log reduction, which reduces that 1 million colony down to 1 living microbe. There again, there's still that one. And I'm sure we're all familiar with hand sanitizers these days. What's really significant that is tissue adhesive has had an anhydrous property, so its mechanism of action against microbes is to dehydrate them. This comes, of course, with a greater than or equal to 8 log reduction against the broad spectrum of organisms, and that is achieved within 3 minutes. We have seen earlier where it was 6 minutes or 30 minutes or longer. What the tissue adhesive does is it acts to seal that insertion site. It immobilizes the microorganisms and inhibits migration. Bottom line is that tissue adhesive provides a broad spectrum microbial barrier and a physical barrier once it's cured. Pretty significant. When we look at tissue adhesive with broad spectrum infections, it was an article in 2017 that looked at the sealing of the insertion site and would it provide a sterile barrier to eliminate extraluminal colonization and decrease pistoning. This is a really hot topic because, you know, when we're applying tissue adhesive, a novel idea to an insertion site, we are telling them that that puts a seal around that insertion site, and that it seals off if there's any little cracks or little openings. It actually just seals it off. But when they looked at a university hospital, they looked at a small number, only 19 CVCs exposed to tissue adhesive for 10 days. They saw no reactions in the skin, no cracks in the seal, that bacterial colonization was less than reported. There were no chemical degradation with the CVC and the tissue adhesives, which is important because a lot of people will ask, well, is there any reaction to the catheter and the tissue adhesive? And we have seen none. They also found from this study that it offered a promising solution and really provided evidence to support us for that 7-day intact seal. Lots and lots of work going on with this currently. A lot of studies are truly looking at that bloodstream infection rates. As I mentioned, we are so fortunate to have no CLAPSIs at this current moment. And it's significant when you see that there were some before, and now just by simply applying tissue adhesive at an insertion site, we are seeing such success. So when we look at what I've just gone over with you, we're looking at some key takeaways of the use of tissue adhesive. Looking at improved securement, therefore it reduces the unnecessary restart of PIVs, migration and dislodgement. When we're protecting that insertion site, I believe that it truly does reduce risks of bacterial contamination at this insertion site, as evidenced by our CLAPSI rates. It is cost effective when you compare that you just need tissue adhesive and an occlusive dressing. There's no need for securement dressings. There's no need for those other securement devices. Protects the clinician. There again, not the unnecessary ins and outs of reducing dressing changes and avoiding unnecessary patient contact. And then again, for those isolated patients, it does save on PPE. Even though we are in there looking at it several times a day, which is one benefit too that I didn't mention, that you can see the insertion site with the glue. It's not covered by a patch or some gauze dressing. You can truly just see that insertion site and be careful to observe for it. So I think it's very valuable and important. So in summary today, I'd just like to go through some of the evidence that we talked about. Looking at tissue adhesive, that it's effective against gram-negative and gram-positive yeast and fungi, and that tissue adhesive provides that 8-log reduction in microbes within 3 minutes of contact, which is less than what others have with the hand sanitizer, etc. That it immobilizes microbes that survive on the following standard prep, so we can clean off, and the use of the tissue adhesive at that insertion site continues to immobilize microbes. That it's safe to use at all ages and in all vascular access device. Now, my study was just on PICCS. However, we are hoping to move forward with a multi-center study with peripheral IVs, hoping to be able to change practice completely over to tissue adhesive to seal and secure that insertion site and to prevent migration. Evidence shows, as our study did too, that there's a reduction in pisting, micromotion, and it reduces migration, which was an important factor for us with the PICC line. And that there is that added cost savings. It reduced complications and eliminated other products, simple to use. Little education was required, and I can't stress how much that was, that truly it was so easy to implement. So with that, I have included several of the references that we used for today's talk. And also, if you're interested in contacting me, please do so. I'm more than willing to share any other information that you may need or want to hear. So thank you very much, and thank you for the opportunity to be able to present this information.
So we have quite a few questions for you, and I think we'll get right into that right now. This is the end of the educational portion of the show, and if brand names or anything like that are spoken now, the CE portion is behind us. So we have a little bit more latitude on that.
And it's all about you guys. So, please, any information, things you want to see, things you want to share, things that you need, don't hesitate to reach out.
And to that point, Adhesion has said that we can send a PDF of the slide deck. So again, send an email to Blake, avaed@avainfo.org. He loves to hear from you guys. So let's get right into these questions. Did you track CLABSI on all bloodstream infections, or did you just track CLABSI, or all bloodstream infections?
So our experience is that they're tracked with those that are reported. So if a blood culture comes and it shows CLABSI, then it's reported and tracked. But no, we didn't track every single patient on the study for CLABSI. And the reason for that was the cost. And how do you effectively do it? Would we have to start with blood cultures at the beginning, and then after, when the catheter is removed, and every person that enters that line, it's hard to define a CLABSI based on that. So no, we did not.
Thank you. I'm going to follow up real quick on that. You did mention that the one CLABSI you had was not attributed to glue. How did you determine that?
That wasn't myself that attributed to it, but the individuals that went and looked. This patient had many, many, many lines, was a patient that had come from intensive care. The fact that one last pick that was put in had growth. Could we attribute it to it? Or could we attribute the CLABSI to the glue? The glue was only on a short period of time. I want to say maybe 7-8 hours. Was that really appropriate? It was tracked because of the fact that the patient did spike in temperature and of course did come up several organisms. The organism that showed most was a colorectal organism. So not sure exactly where that came from or exactly, but they had confirmed we did have to track it as a CLABSI, but they truly felt that it wasn't related to the tissue adhesive.
Speaking of infection prevention options, when you're using a tissue adhesive, can you use a silver disc or a biopatch or some sort of adjunct like that over the insertion site?
I know that there are several centers that are doing that, but we chose to go directly with just glue and remove any type of stat lock or biopatch.
Yeah. It kind of makes me wonder when we're applying a material over a tissue adhesive, how effective that is at getting at the site when we've already sealed it.
Well, my concern was the interaction between that chlorhexidine being constantly emitted and the glue. Was there any effect? But my colleagues have indicated that there probably is not, but that still makes me wonder, why would you use it if you know that you've got that seal? Is it doing anything to that seal? I know you can clean over it without any concerns in that, but to constantly be admitting that chlorhexidine, I'm not sure that that's wise, but that's just Joan's thought.
Here's another question that I got in an email before the show yesterday, and they were talking about, speaking of site issues, in patients with high amounts of edema. So we've all seen these people, they got the weepy skin from the insertion site. Any kind of puncture in that skin is just going to be a portal for fluid to come out. How effective is tissue adhesive in its ability to secure properly to the epidermis around that access site?
So for that answer to that question, that patient would have been excluded in our study. We would not have used that patient if they had intact skin. However, I will say to you that I have a colleague that works in a burn unit in the northern states and has used glue for burn victims successfully. As I mentioned, in our patients, we excluded those that their skin was not intact. So I really can't comment on that.
Yeah, and I'm thinking, when he posed that question, at the time of insertion, it may not have an issue because that weeping may not be occurring at that time, and it's more of an observation that we might see down the road, depending on how long a device stays in place for.
And that was, we did not have any situation like that reported. So sorry, I can't comment.
Yeah.
Do you do the same dressing change at Q7 days? And does the adhesive get loose during those dressing changes?
Yes, we do our dressings every 7 days, or unless it's needed. As far as the glue, you know, it depends on how much glue is there, but usually it has disintegrated some around the insertion site. So it usually just comes off and then we're able to apply more glue. There have been instances where the glue has remained and, you know, we put more fill the area and getting it built up on a catheter is what we found. So the experience that I've had is that it normally just flakes off and it releases from the skin, and then you can clean and reapply the glue to the insertion site.
I think that's one of those things we earlier on in the spring we had Adhezion on, and that was one of the common questions was what does the care and maintenance look like for devices with tissue adhesive and how effective it is. So yeah.
I know that in our ambulatory population, you know, when you've got a confined or a population within a hospital inpatient, you really have a lot of control over how that dressing's changed and what's applied to the insertion site. But when the patients go out into the community, it's a little more difficult. We at first started sending our patients out to the community with the glue on, with a letter indicating that this is what was on it, that, you know, it wasn't left with nothing. And we found that a lot of the community individuals, even though we had sent a lot of education with them and information, they still were so eager to open up that site, to get that glue off and to put a bio patch on. And we found that it was so used so strongly that in our ambulatory setting, they have gone back to using the bio patch with those patients that are being discharged to the community. And that was because of the fact that we felt it was better to not be in to that site all the time, you know, to open up again. It was better to start off that way. But that was only, and that's just of recent, that was only for our patients in the ambulatory clinics. Yeah. Until we can get everybody using tissue adhesive.
I think that's the, you know, whenever you look at making an innovative change somewhere, you work in this really small subset, and it's the downstream effects when patients go home and they're in basically the care of maybe a different organization or a different subset of your healthcare system.
I will not forget the first phone call I got that, what was I doing? Did I not know the INS standards? Did I not know the AVA standards? Did I not know every standard possible? And how dare I send a patient out with just a clear dressing over top? They were furious, but
all these questions.
Yes, and they were sent out with information, but they still questioned.
How about I think you had mentioned that the pediatric study wasn't really part of your design with this. Have you heard of any, or do you have any colleagues that are looking at tissue adhesive application with neonates or peds?
Yes, there are several that are. So I would have to contact my colleague to get that information of each place it is, but there are several institutions that I'm aware of that are either trialing it or using it.
And I think that segues into another question from our listener, which was, you know, pediatric insertions often bleed after insertion. If the glue seals the insertion site, does the bleeding continue under the skin, creating a hematoma? Did you see that at all in your adult population?
On occasion, we have seen maybe one or two, but that's all. We did at first, you know, when you're first learning how to apply this glue, we did see that there was bleeding that occurred after it, and came to realize that we really hadn't got the bleeding stopped before we applied the glue. And when the glue and the blood mixed, it truly didn't set up as it should. So we found that it was very important that we get a good seal, or not a good seal, but a good coagulation before we apply the glue. So that was really important that we did. Maybe 1, 2 hematomas we saw, but no, nothing, because we had definitely tried to make sure that the coagulation took place before the glue was applied.
You know,
I mean, there's lots of studies out there that are showing, you know, the intraoperative use of glue. So, I've read quite a few of those as well, and it seems there too they look for coagulation before they apply it to the anastomosis of what they're doing. Yes, Judy.
one of the questions, sorry about that, I didn't mean to interrupt you, but one of the viewers is asking about evidence in the NICU population, and real quick, there are no age limits on this. So
I don't know that answer.
that one I do.
Okay. Good.
There are no age restriction. So
Okay.
I know there's a paper that is in the approval process right now that has been submitted into the journal that is specifically about NICU and the use of tissue adhesive. So absolutely.
Great.
Let's see what else. How long does the tissue adhesive last?
They say approximately 5 to 7 days is what the literature suggests. We have some patients that it lasts longer and others that would be more on the end of the 5 days. So, and I know that was a concern from our nurses, is that if it only lasts 5 days, what's holding that catheter in place? As mentioned, we use a securement dressing over top of it. But I would say the majority of our patients, if I could estimate a time, would probably be around that 6.5 day mark. So, but that's just Joan. I have no scientific evidence to support that.
Yeah, I was going to say one of those common questions or issues we see is, dressing disruption in the care and maintenance phase of the life of a vascular access device, and how pivotal or critical something is like a tissue adhesive in order to not only secure the insertion site and maintain its integrity, but also to add some additional integrity to the dressing as well.
Right.
In your study, was this exclusively like hem-onc patients?
We started on 7 West at the hospital, and the majority of patients are hem-onc. The reason we did that was that's one of the units that I oversee, so I had a little bit more eyes on them, shall we say. But our patients, it is a med-surg unit as well, so there were definitely med-surgists. And when we moved to incorporate another unit, it was more cardiovascular. So the beginning, the 30 patients, I would say maybe 2/3 of them were on patients. We did use the glue on all the new leukemias that came by. We did not, we excluded those BMT patients. They didn't feel that they wanted to have them as part of our group. But the new leukemias were introduced to the glue, so I went through the process with it. They seem to really respond well. When you think of when they're immunocompromised, they seem to really, really benefit well. Number 25, patient number 25 would go around singing, because we numbered the patients on the study, and he'd always come to my office and say, number 25 reporting in, and he'd show me his line, and he had it in for months with no problem. So, I really, of the 31, he was the one true success, I think, because of the fact that he was a hem-onc, immunocompromised, and yet still did not have a collapse, or any type of a line infection, bloodstream infection.
Yeah, and maintain that device for the whole time.
Yes, definitely.
Did you track all of the dwell times for all of your catheters?
I did. I tracked all the dwell times for them as well, too. Mm-hmm.
How frequently are you reapplying on short peripheral catheters?
We are not using that yet. We were just about ready to embark on a study with peripheral catheters, peripheral or PIV catheters, with another Mayo site. We wanted to get a lot of patients on this study, and we're looking for Rochester to join us, and then COVID hit. And so we've not done anything with that study yet. It's on hold at the moment, but we were looking to just to use that with the peripheral IV catheters. So I have no information on PIVs. Our study population were PICCS.
Maybe same time next year. Come on, Joe.
Yeah.
Let's go.
Yes. Well, I would love to do it. It's just COVID really has put a stop to a lot of things. So we're starting to open up on things. And so maybe we can start looking at that again.
Hopefully.
There are many centers that have studies going and that have changed right over their practices to the glue with peripheral IVs. So I think that maybe we should just go ahead and do it. But we were looking at different options as well. So, and Mayo likes to study.
Yeah, well, that's a good thing because we need studies to really prove.
Yes.
In your study or in your practice, have you found the patients complain of pain with removal of lines? So they're removing the PICC, do they complain of pain?
With the tissue adhesive on it?
Yes.
None. There is a way that dear Marcia showed me how to remove it, and we have done that and very successful. So thank you, Marcia.
So here's a question about securement devices. So you guys use a securement dressing.
Yes.
Are there other types of securement devices? This was from one of our attendees. Could it be used with staples or with or without a dressing? I'm guessing in the case where you might have someone who has an allergy or has a gauze dressing.
Or even
I don't know that. If you look at the theory behind the glue, I don't know. I know that back in the day in Canada when we had our central lines and our patients, once the cuff was healed on the central lines, our patients did not have dressings and they did not have any infections. They were fine. They just had a little piece of tape on the catheter and pinned to something so that it wouldn't get pulled out or whatever, but they were maintained without a dressing. So if you look at the theory of the glue providing that seal, I guess I'm a little bit of a, shall we say, a pioneer. I think that we could do it, but so many people are not necessarily that eager to try those types of things because of the risk of collapsing, and I understand that. But the securement dressing is just a dressing that goes on and it has at the bottom like the pants and the top or whatever it's called, they all say, and it just provides them an additional securement to that catheter at the end.
And I think to the point about staples, though we don't recommend staples with any catheter,
or sutures.
Correct. But it does seal the hole. And many of our visitors are not, or our attendees are not from the United States. So if you're working in another country and you use staples, though we prefer you went to glue or a securement device, of course, it's going to seal that hole. And I would say it's better than nothing if you don't have a dressing.
Exactly.
But
I'm not advocating no dressing, but I know that my colleague who is the burn population, I know that she does not use any other dressing but the glue at the insertion site, and then especially if the patient's burned quite a bit over their arms or wherever the PICC is associated, that she'll just glue it and then we'll loosely apply gauze to keep it somewhat stable, and has good success, with that. She has found it tremendous that that they're able to maintain patients with minimal amount of air to the skin.
Yeah, I think that's a great example of when that would be probably one of the most ideal scenarios.
I agree. I know that they were talking about weepy skin and that, but as I said, with our study, we had the luxury of picking and choosing. That was when we decided not to use anyone with open skin and that, because of the fact that we were trialing it for the first time. Maybe now we could get a little bit more eager and challenging and to see, but it's a hard call to be able to throw away a dressing and just say, we're just going to use glue. It's not something that's conventional. Everybody wants to put something over it. So I don't know if it would work. I think it would, but there again, those dressings are just like, do I think a simple Opsite or Tegaderm would be fine over that? Absolutely, absolutely. But haven't convinced anyone of that yet.
Here's a question for you as far as care and maintenance goes. Again, a common subset. Do you recommend changing the dressing if there's any blood showing? Or did you, I guess in your study, if you saw
Did we?
blood on the site, would you have changed the dressing or reapplied the glue?
It depended on the amount of blood that we were seeing. If it was completely saturated, of course, and if it compromised that dressing, of course we did, because then we felt that at that time the glue really hadn't had that opportunity to form that seal. If there was just a little bit of blood, no, we left it. But there again, it was totally individualized. And so looking at, the amount and whether or not it needed to be changed.
Did you include confused patients in your study by chance?
That wasn't something I assessed. They had to be available to be able to sign a consent. So with that being said, the nurses consenting would be evaluating whether or not they were able to consent. So I would say no, that there weren't any confused patients. But that's not to say they got confused later on. I don't know that. That wasn't something we tracked.
In any of the cohort, did any of the participants pull their catheter out?
I don't, on the 31, I would say no. On the 411, I would say there was one or two that decided that they didn't need any catheters that day and tried to pull and pull and pull. One was very successful. He must have seen the technique that Marcia gave me, but he did remove his, but not completely, but it's still, they had to take it out. But there was just one, maybe two, if I recall.
Thank you. And we've had a couple of questions about NICU and pediatrics, and some people need more information on, can they use it on Peds? Can they use it in the NICU? And I know there are many people across the country using it now. If you reach out to Adhezion or email Blake at Ava ED, I have everything gets sent to Blake. It works perfectly here.
Hey, Blake.
We can hopefully get you some more resources on that.
Or if you're in the survey and it says, would you like to hear more from Adhezion?
Absolutely.
Please, that'll help too.
And
just get you more resources.
And as you folks that are neonate specialists and pediatric that are using it, if you wouldn't mind just emailing Blake, again, Blake, and letting us know, because the other people that are interested need resources, and we would love to get you guys in touch. We'll be your matchmaker here on that. Can you use it on weeping skin, scaled skin, and obviously on PIVs?
I'm sure people have, but we didn't.
I mean, as an aside, I have one in my purse when I'm getting a blister on my foot. I use it pathologically. So I don't, that is off label, but.
Yeah, I have one too that I use for cuts and fingers. I don't have any more, so I can't use it, but totally off label. But boy, the next day I don't even have anything, so pretty good.
Well, I'm gonna end it up with this last question, and we appreciate the time. Did you find your dressings lasted longer?
I don't know if I can actually comment on that because they would have been changed 7 days.
Very good. Joan, thank you so much for the information you presented today. And I appreciate all the information, all the input from the listeners today. If you're interested, go to Ava Academy. You can go to avainfo.org and see all the webinars we've had in 2020, and the content from conference will be on there soon. I hope you're having a great day. Stay safe out there, and we'll see you next time. Bye now.